So you're really, as was kind of alluded to before, it doesn't really make many of our first principles, really, the idea of treating locally for a widely metastatic disease, and so I'll come at it from that standpoint. Here are my disclosures. This is a case that was referred to, an 86-year-old man, heavy smoker, but actually had been doing well until recently developed a cough and weight loss. So his initial presentation in February of this year, a coronal PET scan, really quite a large lesion, looked on body imaging to be actually localized disease, limited stage. But unfortunately, a brain MRI showed a single brain metastasis. He got stereotactic radiation to the brain. Actually, the whole brain was discussed, but at his age, he decided not to and got stereotactic and got platinum etoposide, carboplatin etoposide chemotherapy, tolerated it really quite well. And then 3 months later, here's his follow-up PET scan. I tried to get the same slice and really had a major PET response and close to a complete response, but there is still some residual disease there. And actually had a great CR in the brain. So that was very gratifying. And what do you do next? And so we thought we'd just take a second to vote on it. You've only heard the pro, so I'll see if I can convince you afterwards. But here's your pre-vote. All right, I'm ahead. Okay, maybe I should stop now. Great. Okay, so actually we have a lot of the same slides. How did we get there? Get here, I should say. Radiation for limited stage. 20 years ago, initially showed that adding radiation to chemotherapy for limited stage had a real statistically significant, but you see not huge, but some benefit in survival. And then the trial of also in the New England Journal of BID versus daily radiation led to that being one of the options. Criticism of the trial is that the BID dosing of radiation really significantly increased the biologic effective dose. But nevertheless, they had a nice significant benefit there. So then can we bring that to extensive stage? And same trial from Ben Slotman in Netherlands as leading this very large program, 42 hospitals across Europe. Patients were evaluated for brain disease at baseline, but PET scans were not mandated and there was no reporting of their use. Patients were randomized 1-to-1 to get radiation or not. All patients got PCI. So I think probably from a statistical point of view, the most important thing is the primary endpoint was not met. The overall survival at 1 year was not significantly different and numerically different, but not hugely different, and median overall survival was identical. So then if PFS, not surprisingly, was better, if you start looking at multiple endpoints, then you do have the chance of finding something significant at 2 years. There was a real big difference in overall survival, but as I said, these were there was some post hoc analysis, and this was initially a secondary endpoint, but it wasn't their primary endpoint. If we look at the subgroups, it's written small, but I just want to point out, as was previously discussed, the benefits confined to a small tail beginning at 1 year. Primarily younger patients and women, and younger in this case is under 70. Seem to have benefit. Patients with intrathoracic disease at randomization, and also importantly, patients that were described as extensive stage due to intrathoracic extensive disease. They were among the patients that seemed to derive particular benefit. So I'm going to come back to that issue later. And just as was recently described, also this trial from 20 years ago showed with really quite an unusual regimen of daily chemotherapy. Let's see, all patients got at least 7 cycles of chemo, but some more. And really quite a bit of toxicity, significant grade 3 and 4 esophagitis and pulmonary complications. There was some patients doing well out several years. So this debate's a little bit similar to the PCI debate. And so going back several years to the ASCO plenary session with PCI, an improvement in symptomatic brain metastases was expected, but the overall survival improvement was unexpected. And so this type of concept was repeated and reported last year from Japan, where they did, I would say, a stricter study. All patients had to have a brain MRI at baseline, which was not required on the Slotman trial. And there was more rigid requirements for what the whole brain radiation had to be. And here, in fact, they saw a detriment in overall survival from the PCI. So with incomplete staging, there seemed to be a benefit. Some have thought that we know that some of those patients that didn't have MRIs must have had, just statistically, some significant portion of them probably had brain disease that was treated with PCI unknowingly. And so perhaps if you take those patients out, you're only getting a detriment from the PCI, now that we have a modern staging trial. So again, as I suggested, going back to first principles, the overall survival of systemic disease we think is primarily determined by systemic therapy. If there's a benefit from local therapy in systemic disease, presumably that patient has oligometastatic disease. I am going to talk in a little bit about oligometastatic non-small cell lung cancer, but small cell lung cancer is really our solid tumor epitome of systemic disease at diagnosis. So my sense is if it doesn't make biologic sense, it's probably not true. That's my overall feeling. So getting back to this case, what do you do next? I'm almost done, but just to say what he did. I did refer him back to Percy Lee to discuss thoracic radiation. The patient during that time got a follow-up scan. Actually, his disease got even further better off of therapy. So now really in my eyes, there's no clear residual disease. So actually not clear that he would fit into a group that would be expected to benefit from the Slotman trial. And the patient, 86 years old, was hesitant to undergo more treatment, and so perhaps sometimes patients are smarter than we are. So in summary, reasonable to expect improved progression-free survival, certainly radiation to symptomatic or perilous sites, impending SVC syndrome, et cetera, is very appropriate. It seems to me unreasonable to expect improved overall survival in most cases of extensive stage small cell. Evaluating from that Slotman trial, multiple endpoints increases the chance that a random event will appear significant, and particularly if your primary endpoint is negative, it becomes less clear how that trial should be viewed as positive. So, and then lastly, based on that staging question, at least some of the patients that benefited in the trial were likely had disease limited to the thorax, but could not be safely radiated. So I wouldn't say that the chemotherapy downstaged them, but it just made the delivery of radiation safer. So in my view, it should not be the standard of care. Thank you very much for your attention.